Right? Good evening, everybody. My name is Jeremy Wimpheimer, and on behalf of Tzohar, thank you for joining us. Tzohar Admei ועשרים, Tzohar through 120, was launched as a program of the Tzohar Center for Jewish Ethics with the vision to help people and families at some of their most vulnerable moments, and with the understanding that respecting our parents and loved ones, particularly in the toughest of times, is a core Jewish and human value. Now, the concept for our program is to provide practical, ethical, and halachic support when confronting very difficult medical questions. And we do this by bringing together rabbis with social workers to help navigate these deeply complex questions. As we'll have the chance to discuss tonight, issues can range from whether a loved one can be taken off life support to whether and how to continue with feeding support, among many other individual and deeply personal questions. We are proud to have helped many families navigate these complex issues, and our hotline is available 24 hours a day, 6 days a week, here in Israel at *9253, with staff available in Hebrew to help in Hebrew and English. Before we begin, we just want to thank our partners this evening from bnefsh, who share our vision for the importance of this issue for so many people across Israel and around the world. And I invite Yitz Motzin to share some greetings on their behalf.
Hi, good evening or good afternoon, depending on where you are. First of all, I just want to say a Kara Tov to Tzohar. On a personal note, I have had the pleasure of officiating at a few weddings through them, and the bride and the groom have had always the highest praise for the entire process. I have. Tzohar in so many different areas is doing tremendous things for Am Yisrael and Eretz Yisrael. So first of all, just a Kara Tov to Tzohar. I also have the pleasure of working for Bnefsh at a time when people are living longer. I was speaking to one of my colleagues, and they said they had an Oleh who was 102, and more seniors than ever are making Aliyah, and therefore more questions are, of course, arising as well. And one of the things that I think Bnefsh really changed was not necessarily the number of people making Aliyah, but people making successful Aliyah. And in that vein, we not only have an entire pre-Aliyah department, of which I'm one of the advisors, but a robust post-Aliyah department that helps and continues to help our Olim for many years after Aliyah as well. So it is a pleasure and an honor for Bnefsh to be partnering on this important webinar. Thank you.
Thank you. But just before introducing our panelists, we invite you to share any questions you might have over the course of the program. You should put them in the chat, and we'll take questions at the end of each session. We'll have 2 sessions, and we'll make every effort to get to as many questions as possible. And with that, I'm honored to present our panelists this evening. We have Rav Yuval Shurlo, is the director of the Tzohar Center for Jewish Ethics and a world-respected expert in issues related to ethical practice and halacha. And he regularly consults with government boards, the Israeli military, and hospitals on many issues related to medical ethics. And we also have Professor Charles Sprung, who's the Director Emeritus of the Intensive Care Unit at Hadassah Hebrew University Medical Center in Karam, and with decades of clinical experience related to caring for the elderly and severely ill. He has researched and written extensively on issues related to ethical practice in medical care. In 2015, Professor Sprung was the recipient of Bnefsh's Bonei Tzion Award in the Science Foundation for his leadership achievements in Israeli medicine following his Aliyah in 1990. And with that, I am honored to turn the Zoom over to Professor Sprung, who will open our first session on the topic of medicine. Professor Sprung.
Thank you very much. It's a pleasure to be here this evening, at least in Israel. I see there are some people from the States also. My topic today, the first one at least, will relate to palliative medicine and palliative care. Palliative medicine is the study and management of patients with active, progressive, far advanced disease for whom the prognosis is reduced and the focus of care is the quality of life. When describing the care offered by a team of doctors, nurses, therapists, social workers, clergy, and others, it's more correct to refer to palliative care. Palliative care provides relief from symptoms, including pain, shortness of breath, fatigue, constipation, nausea, loss of appetite, problems with sleep, and many other symptoms. Perhaps most important, palliative care can help improve quality of life and provide help for families. Many adults and children experience serious illnesses, not just from cancer, but also from heart, lung, kidney, neurological diseases such as multiple sclerosis, ALS, or Lou Gehrig's disease, AIDS, cystic fibrosis, and other diseases. Patients experience physical symptoms and emotional distress from their diseases, but symptoms may also be due to medical treatments that they are receiving. Palliative care is not just for the end of life. This is a major misconception that many people have. Many patients with chronic diseases suffer for months or even years. It's never too early to start palliative care. Palliative care can occur at the same time as all other treatments for illnesses occur and does not depend on the course of the disease. It can be performed in a hospital, in a nursing facility, or even at home. Palliative care does not depend on whether one's condition can be cured. The goal is to make the patient as comfortable as possible and improve their quality of life. Palliative care provides not only symptom relief, but also helps with the understanding of an illness and discussing the various treatments, coordination of care with all the healthcare providers, emotional support for the patient and the family, open discussions about various treatment options, and assisting the patient and the family to cope with the experience of living with a serious illness. One does not have to be in hospice or at the end of their lives to receive palliative care. Palliative care can be part of hospice, but doesn't necessarily have to be. When we talk about hospice, we typically talk about a person's final months of their life. And most hospice patients live for less than 6 months, but some live much longer, even longer than a year. Early palliative care improves quality of life and even survival. In a study of early palliative care for patients with metastatic lung cancer, patients were randomly assigned to receive either early palliative care with standard oncological treatments, or in a second group, just standard oncological treatments alone. Patients assigned to the early palliative care group had a better quality of life and had less depression. Despite the fact that fewer patients in the early palliative care group received aggressive end-of-life care, their survival was longer, 12 months versus 9 months. I repeat, because it's hard to understand that patients who receive none or much less treatment to extend their lives and just received palliative care for their quality of life and to take care of their symptoms actually lived longer. I will now discuss the Israel Terminally Ill Law, Achok Anotel Lamut, which has important implications for patients who need palliative care and those who might have advanced directives, which is the second topic for this evening. The law provides mechanisms for advanced medical directives, the appointment of surrogate decision makers, and accepting family information. When I made Aliyah more than 30 years ago, I asked one of my friends who's a lawyer what the legal status of a living will is in Israel. And he said, that's an interesting question. It depends on who your doctor is. If your doctor respects your wishes, he can accept the living will. However, if he doesn't want to, there's no legal requirement that he follow your living will. Things have changed, and with the terminally ill law, physicians must respect advanced directives, which we'll talk about more in the next session. Now, the terminally ill law provides palliative care as a citizen's rights. It's interesting that Israel was the first country that included a law with palliative care. The law also obligates the doctor to do as much as possible, not only for the patient, but also for the patient's family. But can doctors provide treatment that may hasten a patient's death? The law obligates the doctor to do as much as possible in order to alleviate the patient's pain and suffering, even if it might unintentionally shorten that patient's life. Active euthanasia, physician-assisted suicide, and intentionally shortening the patient's life are prohibited. In addition, the law also prohibits stopping a continuous treatment, such as a ventilator, but allows stopping an intermittent treatment, such as dialysis. I would like to end with the following thoughts. Terminally ill patients often cannot work, travel, exercise, or do many of the things they love to do. Sometimes they can't even get out of bed or even go to the bathroom. They lose their independence. Anything that provides them with autonomy, control in making decisions for themselves can be empowering. Therefore, palliative care, deciding on how much treatment to prolong life or to improve quality of life, is extremely important. Death is not a medical failure. Life, in fact, is a terminal condition. Physicians and nurses have a duty to cure, but if they cannot cure the patient, they must perform their duty of providing care. As an intensive care specialist, some of my most gratifying experiences were caring for dying patients and their families, not only saving lives. Thank you very much.
Shalom to everybody, and thank you for coming, and thank you for having me. Starting with apologizing that I speak the most common language in the world, and that is lousy English, but I'll try to do my best. What is the main goal? What is standing in front of us as rabbis when we are talking about palliative care? Actually, before we can even start talking about it, there are two main obstacles and two walls that we must break before we start even to deal what is permitted and what is not permitted. The first one is the conversation. Many people think that Al tiftach pe l'satan, the right thing to do is not to talk about death, because the devil will use the advantage and the opportunity to sneak in, and therefore it's not a thing that you're talking about. I don't know if you know, but in Hasidic yeshivot, some of them, they don't study even Hilchot Avilut until they are meted by personally, but they don't learn even parts of the Gemara that deal in the end of Masechet Moed Katan with those issues. And the reason is death is something that is outside of the discussion. And in order to break this, I'm not sure you'll believe me, but years ago, there's a Kartis Edi, when someone signs that he is willing, if he'll have brain death, to donate his organs, then he signs this card. But many rabbis were against, not because of halacha reasons, but because dealing with Al tiftach pe l'satan, and they insist that the words on this card will be changed because it's something that you are not talking about and not speaking about. That's the first thing. It's not the biggest one, but you know, when it's emotionally, and the first thing that we did in ועשרים of Zohar is actually to change this image and to explain and to understand that everyone should, his approach towards life and towards death should be equal, and understanding that death is part of life, and to prepare yourself is actually what our Avot did. Avraham Avinu did it, Yitzchak did it, Yaakov Avinu definitely were preparing himself and his children before death. So it's a wrong approach. But this is not the biggest goal. The biggest goal that we had when we started this project is to change the image of halacha. And again, I'm coming back to the organ donation issue. Many people think that the halacha is against organ donation. even though that the chief rabbinate in 1987, I mean, it's really unbelievable, said that according to halacha, you should recognize brain death, and therefore there is a way to donate organs. There were many discussions, but in 2008, the law in Israel adopted the chief rabbinate opinion, and since then, the path towards organ donation was open, but the percentage of families that agreed didn't climb up. And the reason was because people thought the halacha is against. In 2016, we gathered all together with the chief rabbinate, with the Zohar rabbis, with the government, with other rabbis, and since then, we started a campaign to change this image. And since then, the percentage of families that agreed to donate their organs when chas v'shalom something happens is really climbing in Israel. It's not only because of us, but we contributed a lot to this process. The same thing is with palliative care. Many people think that according to halacha, whatsoever, you should do everything in order to expand life. You are not permitted not to ventilate and not to do CPR and what you are not nothing. The only thing that you are permitted to do, life belongs to God. Therefore, you are the guide. You have to keep them. And many times I'll call it even torture, but we should do that without considering pain, without considering horizon, without considering any other factor. And this is wrong, because the bigger rabbis wrote different. And they paskin that there are situations where there is a point where you are permitted to say enough is enough, when you are permitted to say, I don't want to be ventilated or whatever. And the point is very sensitive, and this is our job in order to give the advice and the halacha instructions. But in this point, this opened the whole conversation. And as Professor Charles said, it's not only the last minute or the last week or the last year of life. Once you understand that there is something that you should do because life is sacred, are holy, and we really must do everything that we can in order to expand them until one point. And you have to go to the doctor, and you have to take the medicine, and you should violate Shabbat, Chilul Shabbat for pikuach nefesh, whatsoever. But understanding that there is a point where you should change your approach, and you should change the process. And instead of talking about health, you're talking about quality of life, and this passion, and mercy, and do everything that you should do in order to help the patient, help our parents to relax, to be covered with the family, to understand that the right thing to do is to do the best that we can in order that they'll have a silent way of leaving this world according to halacha. Once we did that, then we are starting with all the questions. Where exactly is the point? What are you permitted to do? Who makes the decisions when the patient didn't give orders in advance or whatever? So if I'm trying to summarize what is the main issue in order to open the door to deal with the issue of palliative care, is understanding that according to halacha, until one point, you should do everything. From this point, you are permitted, or even maybe more than permitted. Maybe you must do that. Change your approach, change your goals, change your target, and do everything that you can in order to help the patient, and that he will not suffer that if the day came and he has to leave the world, it's very important to do that. And we shouldn't forget even another thing, and that is that the family must be thinking how to do that for his interests. Thank you.
Thank you, Rav Yuval. So we're going to start with a question which I think either one of you might be able to answer, but it's on the policy or legal level regarding if there's a hospital that's guided by halakha or religious principles and their ethics committee makes specific decisions, is a family able to override those decisions based on personal medical preference or based on their own considerations?
I'll say, according to the law, the family doesn't have any status unless they were authorized by the patient. But they don't have any status whatsoever. It's a decision of the patient, and if he can't make the decision, the doctors and the staff are doing that. But in practice, you can understand that in all cases, actually, it's a kind of a conversation, it's a kind of a meeting between the family and the staff, and they can ask, they can insist, they can go to the judge, try to change the ethical committee, whatever. And actually, this is the reason we are there, because in many cases, we are mediating between the family, between the staff, explaining to the family that the best thing for the patient is, according to Allah, you should do the best thing for the patient, and explaining to the doctors the language, the discourse of the family. And in most cases, it's a common decision, and it's not a conflict. It's a debate, it's a dilemma, and a decision.
So I would also agree, there are various laws, there are various regulations that hospitals may have, but sometimes, and especially if you would go to a hospital ethics committee and explain exactly what the patient preferences are, you might be able to develop some flexibility in terms of what the hospital might be willing to do, especially if it was halakhically permissible, and maybe the patient's family would understand things differently based on the hospital. It's always possible if one hospital is not willing to do something and another hospital is willing to do something, to have the patient transferred to another hospital where that would occur. I remember, and this is before the terminally ill law, I had a patient's son come from Los Angeles. He was an attorney, and he couldn't understand why we were unwilling to withdraw a ventilator. At that time, there had been various cases that had gone to court, and it was unclear whether you could or could not, but it seemed that many of the court decisions were that you could not. And we said we typically do not withdraw ventilators in Israel, but since it's not exactly clear and there had been court decisions that enabled that to occur, I said, I'll be more than glad if you'd like to go to court to help you go through the process and see what the judge would say. I'm not sure I could help you withdraw the ventilator. Even when I was practicing medicine at the University of Miami, I didn't withdraw ventilators because of my own halachic ideas and opinions, but other physicians would. And under the circumstances, we worked things out, and I'll talk a little bit about it in the second session. Many patients who have severe underlying problems in intensive care, you really don't have to withdraw a ventilator, and things take care of themselves if you're not aggressive and you decide to withhold as opposed to withdrawing therapy. And many patients, at least in an intensive care unit, will die within a day or two anyhow, and you don't have to do anything really to hasten the patient's death.
That's interesting.
So we have a couple of questions related to the concept of power of attorney. And one specific question, which could probably be answered and relate to some of the other questions. The question is, if I have complete faith in my children's decisions, why would I need to make an enduring power of attorney? So if you could just address the general issue of what the recommendation about power of attorney, and also from the halachic perspective, the complications behind it.
So if you have full faith in your children, then by all means, you could appoint them as your power of attorney. You don't have to, and you could, you can play the lottery and you go to Las Vegas too. But I've seen different families, and I would say there are many families that at one time seem uniform in their opinions, but someone may become very Haredi, and all of a sudden they have different opinions. But I would say under many, many circumstances, there are various differences of opinion from children and family members. And it's important that the person who has to live through these decisions at least let his children know exactly what he or she would want under various circumstances, because you never know what's going to happen in the future in terms of your children's opinion. There are studies looking at what people would want, and they did questionnaires to the family members to see what they think their parent would want. And it's interesting how different the opinions were about what people wanted for themselves and what their children wanted for them also. So I think it's a very, very good idea. I'll talk about it more in the second session, about having discussions with your family, with your very good friends about what you would want. Because if you really don't know or haven't communicated exactly what you want, when the time comes to make decisions, it can be very, very difficult for the medical staff, the nursing staff, but even for the actual patient's family members themselves, who may even have guilt over making what they think are decisions, when in fact they're medical decisions that the physician should be making.
I agree completely. I want to say something from our experience. Many times after death, the family have really a lot of that torn. And the reason they're torn, because some of them feel that they didn't do enough, and they said we gave up too early. And the other part of the family said, you know what, it was a torture. We should, many days before, we should say, don't do anything, and the whole family is have a lot of problems later. This is the reason, like, why we are in Zohar insist that we'll meet the whole family and everyone will be together, and even if it'll take a little bit more time, it's the right thing to do, because you must think about what will happen later. So when the parents give orders, it's much easier for the family, and the chance that the family will stay united is higher. So therefore, it's another reason we recommend to give the orders in advance.
Relate to the topic of our second session, so I recommend that we move on to that topic. And that topic is basically addressing the inevitable questions and dilemmas that could come with the end of life. So with that, Professor Sprung.
So I would like to start my presentation by presenting a patient that I took care of at the Hadassah General Intensive Care Unit, or ICU, several years ago. This was a 75-year-old man who was admitted to the Hadassah ICU at Karim with severe pneumonia and respiratory failure. The patient was unconscious, in septic shock, a very low blood pressure related to severe infection, and he required vasopressors, blood pressure medication to increase the blood pressure, and was on a ventilator at the time. The patient gradually improved, his shock resolved, but he could not be weaned from the ventilator. And after 2 weeks, his wife was appointed as an apotropos, the legal representative for medical decisions, and a tracheostomy was performed. Over the next month, the patient had several episodes of deterioration with pneumonia, another episode of shock, kidney failure, and continued respirator requirements because of the severe respiratory failure. He was unable to make medical decisions as he required sedation for the respiratory failure. At this time, it appeared that the patient would probably not survive, and the medical and nursing staff asked the family what the patient would want under these circumstances. During the various conversations, the daily conversations that we had with the family. It was apparent that the family never had a conversation, and the patient never instructed his family members of what he would want under such a situation. And the staff explained that given the severe illness that their father or husband had, some people under these circumstances would want aggressive treatment, including CPR, cardiopulmonary resuscitation, pumping on the chest if someone's heart stopped. And if there was even a slight chance that they could survive, even if it entailed suffering, some people would want this aggressive treatment. On the other hand, there were patients who, if they felt they had a good life, and if continued treatment would be entailing some pain and suffering, and the chances were very slim, they would not want aggressive treatment. They would want the palliative care that we talked about before. And we told the family under these circumstances, in terms of what the patient had, we would respect the wishes of the patient in terms of whether he wanted aggressive treatment or palliative treatment at that time. Now, the wife, as a legal representative, had to help us make the medical decision. And as I mentioned, they never had any of conversations about this before, and she really didn't know what to do. Now, she had two children. One was a son who said, well, my dad's a fighter. And under these circumstances, even if the prognosis is rather poor, and even if it means some suffering on his part, he would want the aggressive treatment on that slim chance that you could save him. Now, his daughter happened to be a nurse, and I guess she was more cognizant of what was going on and what would be going on. And she said, it's true, my dad's a fighter, but given the fact that he's gone on for the last several weeks, he is suffering, and he probably will continue to suffer. I think even though he's a fighter, he would not want continued aggressive care that you're providing. Now, we asked the mother to try to help decide based on the fact that she was the legal representative, the apotropos, who had to help us decide. And because she could not, she heard the opposing opinions of her children, she just couldn't decide. So we continued the treatment as best we could. And over the next few weeks, the patient has had his ups and downs, and I would go through a daily update of what was going on. And this went on for about 6 months. And it was becoming clearer that the patient would not survive. And I would ask the wife, because things were getting worse, and it really didn't look like he would survive, if she thought maybe under these circumstances, she could have some idea of what her husband would want. And again, the two children had opposing views, and she could not decide. Finally, after 7 months in the ICU, the patient deteriorated further with severe septic shock. And at that time, I made a medical decision. In my opinion, the patient could not survive, and he continued to suffer as much as we tried to make sure he wouldn't, giving him pain medication and sedation. And as much as he suffered, I think his wife certainly suffered a lot more. Therefore, I gave the order to continue all treatments, including antibiotics, but not to increase the noradrenaline, a vasopressor, the medication given to increase his blood pressure because of the shock. I explained to the family that this was now a medical decision that I had to make based on the fact that I didn't think that their father or their husband would survive, and the fact that he was suffering. The wife and the daughter, and finally the son, accepted this decision based on the facts, and the patient died a few hours after that decision. After 45 years practicing intensive care, this was probably one of my most difficult patients caring for, if not the most difficult patient. Most people do not have advanced directives and have not discussed what they want if they develop serious medical disorders such as this patient. Despite that fact, most patients either get better or die within a few weeks or maybe a month or two, certainly not 7 months. The suffering and distress of the patient, the family, the nursing and medical staff going on for months was extremely difficult to deal with. Therefore, it is extremely important for people, especially those people with chronic illnesses, to have discussions with their families and friends as to what their desires are for their end-of-life care. Now, there are a lot of people on this webinar. How many of you have had these discussions with your family members and good friends? If you had a terminal illness, have you discussed whether you'd want to undergo CPR, be ventilated on a respirator, or be admitted to an ICU? In our Ethica study of 37 ICUs in 17 European countries, which was performed more than 20 years ago, we found that only 5% of ICU patients had decision-making capacity, and in only 20% were patient desires known based on what they could tell us or what the family members could tell us. In a follow-up study a few years ago in the same European ICUs, and in another study in 199 ICUs performed in 36 countries worldwide, we found that only 16 and 19% of patients had decision-making capacity in the ICU, and still only less than 50% did we know what patients wanted. So in a large number of patients, we still don't know what the patient would want, and that makes things extremely difficult for the physicians and the families, because unless you have these discussions, we really don't know what people want. I can't tell you how many family members have guilt over decisions they believe they had to make about their loved ones at the end of their lives, despite the fact that I tell them this is a medical decision I have to make, and I just need information from them to make the best medical decision for their loved one based on what that person's desires would want. There's another important reason to have these discussions. As I previously mentioned, the Israeli terminally ill law provides for accepting patient information for end-of-life decisions. This is rather unusual for Israeli law, and in fact, we place this in the terminally ill law because if a patient requires a tracheostomy, the next of kin cannot just sign for the procedure, as occurs in many different countries. A family member has to go to court, become an apotropos or the legal representative to accept and sign off on the tracheostomies. Family members can have legal standing for their loved ones for end-of-life decisions, but only if they've had these discussions beforehand and they know exactly what the patient would want. Why do I research these ICU practices? First, I've been working in ICUs for many, many years, and that's where I take care of my patients. But more importantly, approximately 20% of hospitalized patients dying in the United States die in ICUs. And of the patients who die in hospitals, approximately half are cared for in ICUs over the last 3 days of their lives. Now, let me talk about legal mechanisms in Israel and around the world which help document individuals' desires for their end-of-life care. These are advanced directives for people who can no longer make decisions for themselves, and they include a living will or a durable power of attorney or ייפוי כוח. They are completed at a time when an individual is mentally competent and able to make decisions, for a time in the future when that person may not be able to make these decisions. A living will is a legal document that states the types of medical treatments someone wishes for their end-of-life medical care. A durable power of attorney, or the ייפוי כוח, is a legal document that allows a person to pick someone, usually a family member or a close friend, to make medical decisions for them if and when they can no longer make decisions for themselves. Now, there are differences between these two documents. They include the fact that an ייפוי כוח allows a person to assign someone that they choose to make decisions for them. A living will only has various statements that the person made themselves. So sometimes the stated situations in a living will not occur, and the situation in the ICU may be different than what was in the living will. And in addition, if an apotropos or legal representative is required, in Israel, one has to go to court, and we really don't know who the patient would want to be their representative going to court. Now, usually a social worker gets involved, and the family decides on who should go, but having an ייפוי כוח and knowing that a person decided on their representative makes things a little bit easier. Now, the ipui koach does not indicate the medical treatments that the individual would want, so it's extremely important for the appointed person to discuss at length what the person would want under different circumstances. I'm the ipui koach for several relatives, and getting to know what they would want, I went through the whole list of the various scenarios in the living will that's on the Ministry of Health website, and went through all those things with them. So even if the exact circumstance might not occur in the future, I have a gestalt of what that person would want and can respect that person's wishes and do what's best for him or her based on the information they've given me. So I've tried to portray for you some of the difficulties that occur when end-of-life care discussions do not occur. I've also attempted to explain what advanced directives, a living will, or the durable power attorney, ipui koach, are, differences between them, and why having an advanced directive is so important. Thank you very much.
Thank you, Rav Sherlow.
Again, first of all, I think that everything that Professor Charles said is so important, and this is from the perspective of the patient, of the family. And I'll ask myself again, as a rabbi, what is my role? What is my job here regarding those issues? Actually, I want to speak about three things. The first thing is that the decisions that we have to make many times are decades before the emergency point, especially when we are talking about dementia. When we're talking about dementia, it's a question of the family, of the children, of the entire situation, and how to behave, how to conduct our life, what should be our approach. Should we start with kibud ava'im and saying that we have to do everything to our parents, for our parents, or according to halacha, the halacha also recognizes our needs, and the idea of that the halacha says shelcha, what belongs to you, kodem l'shel kol adam, especially regarding kibud ava'im. The Mishnah says that if your father lost his wallet and you lost your wallet, actually you are permitted to look for your wallet before, and that is the main source of the trying to make any kind of balance between our commitments and obligation towards our parents and the family, the children, the wife or the husband, or the entire family. So these are decisions that the halacha is part of it, because you ask yourself not only what do you want to do, what's easy to do, what is the right thing to do. So I started by purpose in those kind of decisions, because in our project and it's our rabbis, we see that most of the questions are related to dementia. And years before the problem that the emergency decisions should be made, I think it's a very important point to understand that there are many decisions all over the way. The second thing that the rabbi must help the family to understand, or help the patient, that the idea that what he wants and what's good for him is part of the legitimate things that you are asking yourself, and you are in factors of the decision. I think it's a new thing that many times we don't realize. Maybe 50 years ago, I'm not talking only about the halacha, even medical ethics. I think if you would ask a doctor, should you consider the patient what he wants? Should you ask him? And I think that the answer was, are you crazy? I know I'm the authority. I know what's important. I know what's the right thing to do. And therefore, we don't have any kind of consulting the family or the patient. We will do the right thing according to what we swore when we became doctors. The idea of the autonomy of the patient, that is becoming the most, maybe the first ethical principle. The world is changing, And every time when the world is changing, we have to ask ourselves, does halacha against it? And we are actually demonstrating a revolution, and we are conservative. I mean, conservative meaning shamrani, not the movement. And we think that the world became crazy. And as I said, the secret of life, this is the only factor that, according to that, we must make the decisions, or actually, this is the right thing to do. And the idea that what the patient wants to do is a part of the decision, not the only thing, but part of it. And it's an important ethical base, even from the halacha perspective, not only from the human being perspective. Once you realize that, and you have the sources of that, and you teach that, and you convince the people to understand that, this is the gate they can go through it, and then start to negotiate with Professor Charles and asking what's the right thing to do and what's the best thing for the patient, and here and there. And rabbis, our organization, one of it is to write the idea, the halacha perspective, that actually realize the importance of the patient wishes, will, what he wants to do, and it's legitimate that one in the same situation, one patient, according to halacha, will say, for me, enough is enough, and I don't want to be rescued. I want to stop suffering. And another one will say, my decision is that I want to continue, and I see those pain as something that I'm sacrificing towards Hashem or whatever. And it's a legitimate way. There's not only one way to behave, not only according to ethical principles, but also according to halacha principles. And once we understand that, then the gate is open to try to ask ourselves, what is the best thing for the patient to do? Giving orders in advance can be valuable and can be valid only if we understand that the orders of the patient is part of the decision, or maybe it's the most important thing. But before we do that, we must agree that halacha recognize our the things that we want to do with our bodies, and not according to what sometimes the halacha image is, that what we want is not, it doesn't have any meaning. We have to ask ourselves, what is the only thing that the halacha says, and everyone should do the same thing. Making decisions in advance, is, as I said before, is also important for the family. And I'm talking again from the halacha perspective. The idea of a family being unified is not only a privilege, is not only something that is, good to have. This is part of our heritage. This is part of the continuation. As we know, when Yaakov Avinu called and gathered all his sons, all his 12 sons, there was a lot of tension there, because his approach and his attitude towards Reuven, towards Shimon, towards Levi wasn't, he didn't say the best words that a son wants to hear before his father dies. But the idea that all of them were together there, the Mishnah and the Halacha and the Agadah and our sources are actually raising up this point of being unified. And giving orders in advance is one of the factors, one of the pillars, I can say, that will help the family to do what the parents wanted. Because if they're starting to argue what we think they wanted, or what we think is good for them, or what is permitted according to halacha, and as we know many times, there's someone that thinks this way, and has another rebbe, and he goes according to he follows another instructions of or restrictions of halacha, then the family is being torn up. So if you want your family to be unified and not to try to argue, you should look at that not only as a human being idea of thinking what will be after, but also from the Jewish and from the halacha perspective, the importance of the united family that followed the parents' instructions and fulfilled their willing and their wishing, and did everything they wanted according to what we signed, we as parents, or signed and made the instructions. Now, saying those three issues, the dimension years before, in emergency time, understanding that what's good for the patient is part of halacha, and the unification of the family actually are principles that we as rabbis, we are not doctors, we are not giving medical advice, but when we are opening the gate and actually bridging between the halacha, the fact that everybody wants to do the right thing, and the situation and the patient suffering and feeling and future and horizon and all those issues, bridging those two factors actually are opening a gate to make things much more exact according to halacha, and much more human and full of mercy and passion and all those important ideas that a patient deserves when he is in a critical situation, and then everybody is doing exactly what he wanted that will be done with him.
Thank you. Okay, so if there are any additional questions, you can put them in the chat. But one question we had is regarding the topic of hospice care. And if a family makes the decision that they wouldn't want to take their loved one to the hospital for treatment, where would they draw the line between performing routine care and those interventional procedures or medicines that are necessary to keep the person alive?
So I can talk in general in terms of hospice care. There are different levels of care, and you can continue various life-extending treatments at the same time you're receiving hospice care in terms of symptom relief. And it really depends, again, on the patient's desires and the patient and the hospice physicians. And I've dealt with several hospice physicians who will say, you tell us what you want. We're here to mainly make sure you do not have symptoms, you don't suffer, you have a good quality of life. We will make sure you don't have these problems. But as far as how much radiation therapy you need for whatever, or other treatments that you need, you can decide, and we will help provide those things that you want.
You know, rabbis is a talk when we're talking about, I'm talking our big rabbis from recent or former generation, didn't speak in medical terms, but they said the principle should be the following. If it's a routine care that, and feeding and breathing and whatever, you must continue. If it's something that is heroic, changing trying to do something that is really very extreme, you should not do that when you are in this kind of care. Now, this is not medicine. This is philosophic principles. In reality, it's much more difficult because I said feeding. Feeding in most cases is really necessary, but in some cases it can cause a lot of damage and it's not needed, or there are all kinds of ways to technologies to do that. So when you come to the case itself, you have every case is completely different, and we're not cases. We are individuals, and we are human beings. But I'm talking about cases in order to explain the idea that from the halachic perspective, it's more philosophy than medicine. Then when you have to bridge between medicine and philosophy and ethics, then you should deal and you should, you have the dilemma in every single patient, a completely different one. And that is the place where it's good to consultate with everyone, with the family, with the staff, with the social worker, with rabbis, and come together to make the decision, what is the right thing to do in this situation?
Okay. We had a specifically practical question that I think is relevant for some of the people in the audience regarding legal documents like living wills and power of attorney, which were drafted outside of Israel and other Western countries in the US, Canada, UK, elsewhere. Will those be valid in Israel or do they have to be redrafted?
So I really don't know the answer to that question. I think the most important thing for a physician is knowing what the patient's desires were. So legally speaking is one thing, but as a physician, if I have a living will from the UK or somewhere else, and it's very, very clear what the patient would want, especially in the terminally ill law, where again, there is legal status for the family. And if the family's coming and saying they discussed this, with their father or whatever the relationship is, and look at this document, then for me, if there are no Israeli legal documents in terms of living wills or an ipui koach, that's enough in terms of the terminally ill law to make a decision to do what's best based on the family information. And having a living will from another country would certainly allow me as a physician practicing in Israel to do what's best for the patient.
I want to say something very sensitive, and it's opening the discussion. It's not the bottom line. The family, in most cases, are the address to know what is the patient was the patient or is the patient desire, because they first of all spoke with him, they discussed with him, and probably they're the best representatives of him. But as a member of the ethical committee of a few hospitals, I always very careful trying to check if the decision were made because this is the best thing for the patient, and or sometimes family feel and make decisions for themselves. And it's in both directions. Sometimes they say, we can't take him home anymore. We can't anymore. It's a big mess in all our family. And in more cases, we feel that we want to know that we did everything that is possible. They don't think if it's good for him. They think about themselves, that they want to feel that they are pure and they didn't miss any chance and they didn't make decisions too early, whatever. We want to know that we did the best thing. Now, in many cases, it's not for the patient. So therefore, we have to be very, very careful. Our pre-assumption is that the family are the best representative of the patient, but you always have to check if the decision were made for his good life or for the family.
Okay, thank you. I think we have time for one last question, but this is a particularly interesting question. The person asks, can a responsible caregiver commit to follow the patient's directive? They give the example of organ donation and then choose not to follow that directive after the patient passes away, since the caregiver believes or feels that the decision is halachically not permissible.
I think I'll refer to the Rav on that one.
Yeah, I know. Yeah, you throw the ball to me. I'll say the following. I think that the most important thing is to think about it in advance and try not to come to this corner, because once there is a contradiction between the physician believes in halacha and the patient what he wanted, and there is a contradiction and a conflict, and then the doctor must do or is asking himself what to do, every decision that he'll make, any decision that he will make will be bad. So the right thing to do, and I think in Israel it's much easier because the law supports it, and for now, there is I don't know, will the law look in eventually when this through the period of time that this government is, I'm not saying anything in politics, I'm talking about their ethical opinion of some of the ministers, but at least until now, because the law supports the halacha position, I think that the most important thing is not to come to this point at all. And remember always that you are committed to the patient good life, or if you said that after death, in most cases it doesn't happen.
Thank you to Rav Sherlo and to Professor Sprung and to everybody who attended. Just reminding everybody that all the services of Torah and Vasrim are provided in English, and we also have files that are available on our website, so we urge you to check those out. And the hotline is *9253 for those of you in Israel, and for those of you abroad, please check out the website and you can email. And we look forward to remaining in touch and providing additional opportunities to share programming and content with you. So thank you again to all who participated, and thank you to Nefesh B'Nefesh for your partnership. Thank you and have a good night.
Thank you.
Thank you.
Thank you so much. It was wonderful, very enlightening.
Yeah, thank you. Very informative. It was great.
Thank you.
Thank you.
Thank you very much.
חג כשר ושמח.
תודה רבה וחג שמח.
Thank you.
Thank you.
Will the recording be available?
Yes. There we go. Everybody who signed up will receive an email with the recording.
Thank you so much.
Thank you.
Thank you both very much. Thank you.
תודה רבה. תודה רבה. This was excellent.
Thank you so much, and hatzlacha with all your continuing work.
Send it to everybody.